Hello, friends. So I'll be talking on this interesting articles that are coming as series in intensive care medicine. Uh, Mainly, it will be of good use for all the trainees. So the title is 10 questions ICU specialists should address when managing cardiogenic pulmonary edema. So this asking 10 questions or 10 myths and facts. So these are the series that are coming now in intensive care medicine and a couple of other journals. So these are useful as a brief overview on this topic. So I'll just take you through this over the next 8 to 10 minutes. So acute pulmonary edema due to cardiogenic cause is a fairly common cause of admissions into ICU, especially in patients more than 65 years of age. And it is found that half of these patients more than 65 years who get admitted to ICU are critically ill, and it is shown in multiple studies. And the mortality in these patients who get admitted with pulmonary edema more than 65 years is much higher. So it can be ranging from 4 to 10%. And in these patients, readmissions also is more common. 15% of them tend to get readmitted at 1 month, and 45 to 50% of these patients tend to get admitted within 6 months. So, which means to say, so the patients who come with pulmonary edema need to be comprehensively addressed and managed effectively with a multidisciplinary approach. And death within 1 year is also found to be fairly common in patients who get admitted to ICU with pulmonary edema. So these are some of the statistics that are available. So what are the 10 things that we need to know? So the first thing is, what are we talking about when we talk about pulmonary edema? So as we understand, the pulmonary edema tends to commonly occur in the setting of left ventricular failure. It could be systolic failure or diastolic heart failure. So when there is this heart failure, there is increase in the pulmonary capillary wedge pressure. So when there is a pulmonary capillary wedge pressure happens, so there is increased extravasation of the fluid leading to pulmonary edema. And it is shown that 30 to 80% of them who develop this who have LVF tend to develop pulmonary edema. And these patients tend to have hypoxemia also. So when the pulmonary edema sets in, hypoxemia is one of the commonest entities that tends to set in. And when there is a pulmonary edema, it is important to delineate between cardiogenic pulmonary edema and non-cardiogenic pulmonary edema, which is ARDS. So it becomes imperative that we tend to delineate and differentiate between an infective sort of a non-cardiogenic pulmonary edema and the cardiogenic pulmonary edema, which typically happens with increase in the pulmonary hydrostatic pressure and the wedge pressure. So the symptoms of this, I'm sure every listener would intuitively know about common symptoms. So patient would be quite dyspneic, will be tachypneic, increased work of breathing, and orthopnea will be present. So that's the first thing that we need to understand what really happens in pulmonary edema. So the second thing we need to understand is what is the pathophysiology that tends to happen when patients develop pulmonary edema. So this is just a schematic representation of the pulmonary vasculature or any vasculature. So there is this vascular lumen, then you have this endothelial glycocalyx layer, which tends to line the vascular endothelium. Then you have this interstitium. So when there is increase in the hydrostatic pressure followed by reduction in the oncotic pressure, so this reduction in oncotic pressure, increase in the hydrostatic pressure tends to push the fluid or the water content from the vascular lumen into the interstitium, and the interstitial pressure also tends to increase due to extravasation of the fluid from the vascular lumen into the interstitium. And this, so in mild pulmonary edema, it is shown there is no disruption of this endothelial glycocalyx layer or the alveolar pulmonary vascular barrier is not breached in most of these patients. So in severe pulmonary edema, when there is breach of this alveolar pulmonary capillary barrier or the endothelial glycocalyx layer gets breached, then there is extravasation of these inflammatory cells, fluids, cytokines, and there is endogenous nitric oxide production, and there is a signaling mechanism happens which leads to a lot of inflammatory process and flooding of these alveoli. So, and it is found that the mortality and morbidity is much higher, and patients tend to need invasive sort of an interventions like intubation, mechanical ventilation, where this alveolar pulmonary capillary barrier gets disrupted or derailed. So there was this study by Varghese et al. Which showed in 65 patients they studied, in 25% of the patients there was disruption of the alveolar capillary barrier. And in these patients, they were at a much higher risk of getting intubated and mechanical ventilated. So in any pulmonary edema, most pulmonary edema, it is mentioned there is no breach of the alveolar capillary membrane barrier. But in certain group of patients where there is a breach of this alveolar capillary barrier, so there is an increased sort of a morbidity, and the risk of getting intubated is much higher. So that's about the pathophysiology. So we'll talk about organ crosstalk, which typically happens in these ventricular failure or heart failure leading to pulmonary edema. So what do we understand by organ crosstalk? So when there is a heart failure that sets in, it tends to affect multiple organs, and that is organ crosstalk. So it tends to affect the lungs, it tends to affect the GI system, it tends to affect the liver, it tends to affect the kidney. So affecting all this kidney is something that can happen in heart failure, and this is coined as organ crosstalk because there is a distinctive pathophysiological aspects which leads to affecting these, and which is venous congestion. So there is extensive venous congestion which tends to happen in the lung, in the liver, in the GI, and in the kidney, which tends to lead to organ injury and organ dysfunction. And there can be hypoperfusion of these organs also, and these together lead to inflammation, cytokines, sort of a release on the inflammatory mediators that get released, and there is cytokine storm, which leads to organ injury. And when there is this organ dysfunction, there is increased risk of mortality also that tends to set in. So this is just a pictorial representation of where you have this hypoperfusion that tends to set in with increase in the venous congestion, increase in the venous pressure, which leads to multiple organ dysfunction, which is coined as organ crosstalk. I think that is something which listeners should bear in mind. In a heart failure, there is hypoperfusion on one side that is happening at the arterial end, and there's increase in the venous congestion that happens on the venous side, and together they lead to organ injury and organ dysfunction, leading to increase in the morbidity and mortality. So how to recognize this organ crosstalk? So there are means and ways to recognize this heart failure or pulmonary edema in general we would be talking. So when there's a pulmonary edema, obviously this is very intuitive for all the listeners. Patient would be dyspneic, tachypnea, increased work of breathing, and increased orthopnea. And alongst with this, there would be, so the way we would look at any intensive care scenario is integrating clinical information, monitored variables, investigative modalities. That's what we would be doing in pulmonary edema also. So the clinical signs, one would look at whether they have a pedal edema or they could have a raised JVP. So these are something not to be missed in recognizing there is a cardiogenic sort of a pulmonary edema that is setting. And along with this, what is of value, which is emphasized, is to look at cardiac biomarkers, looking at beta natriuretic peptide or NT-proBNP and MR-proANP. So these are the levels one could do to confirm that the cause of pulmonary edema is cardiogenic in nature. And the third aspect is to look at the imaging aspect. So chest X-ray would very evidently show the features of pulmonary edema, and lung ultrasound could be used to look at the comets to determine the severity of pulmonary edema, and echo has to be mandatorily done to assess the cardiac function, LV function, RV function, whether it's a diastolic heart failure, looking at the filling pressure. All this will be able to ascertain the severity of pulmonary edema and the severity of the underlying cardiac problem. And the fourth aspect one would look at is the ECG, is something that we have to look at in patients with pulmonary edema, and we have to obviously do cardiac enzymes, thyroid profile, and procalcitonin is done to rule out any infection that may be also compounding the non-cardiogenic pulmonary edema along with the heart failure that may be present. So how do we recognize organ crosstalk? So the way we would recognize organ crosstalk is if other organ dysfunction is present along with these obvious evident features of heart failure and pulmonary edema. So there could be other organ dysfunction. For that, we need to do arterial blood gas, and lactate is an indicator of hypoperfusion in the tissues, and kidney function test to ascertain whether there is acute kidney injury, and liver enzymes to ascertain whether there is liver dysfunction that has set in. So this, I'm sure many listeners would typically see in a patient who comes with acute heart failure. There could be rise in enzymes, there could be rise in the creatinine, and there would be acidosis that would be prevailing, and there could be lactic acidosis that may be present initially. All this indicates there is hypoperfusion, arterial hypoperfusion, and there is a venous congestion, both components having a interplay, which we call as organ crosstalk in this sort of a situation. So these are the variables that one would integrate to ascertain the severity of heart failure, and it also help us to prognosticate and treat them effectively. So that's the fourth point that we need to know. So now the fifth aspect is, what are the goals of management? So the goals of management the emphasis is on preventing hypoxemia by giving adequate supplemental oxygen, and avoiding and preventing hypoxemia becomes the key tenet in pulmonary edema. So obviously when they're hypoxemic, you have to supplement oxygen and make sure that they don't remain hypoxemic, because that would lead to vicious conundrum of organ injury and other organ dysfunction and failure. And the second aspect is to maintain adequate blood pressure and making sure not allowing for hypotensive episodes, or not maintaining very high blood pressure, which can worsen the pulmonary edema aspect. So maintaining adequate blood pressure, if needs be with invasive monitoring, remains the quintessence in effective management of heart failure. And the third aspect which is emphasized is to reduce the extracellular fluid by effective usage of diuretics is what is emphasized, and this has shown to improve the outcome in patients with heart failure and pulmonary edema, and most importantly, treating of the underlying cause. So this is in essence the key components of management which one should address. But if you look at the hard evidence for any of this, these are all fairly intuitive and quite archaic for us to understand that yes, we have to maintain good oxygen, adequate blood pressure, and we need to reduce the edema and treating the underlying cause. But there is these are all based on expert consensus, and there is no hard sort of a data to say that these are the modalities which has changed the outcome. But it is fairly, but for extracellular fluid, there is some evidence to suggest effective management of preventing or treating extracellular fluid improves the outcome. So how to ensure adequate oxygenation? So it is mentioned that in patients with pulmonary edema, there is 20-fold increase in the work of breathing, and there is 20-fold increase in the oxygen consumption. So the effective way to optimize oxygen is obviously give oxygen, but the most effective way, especially when someone is in pulmonary edema, is to give non-invasive ventilation. And this non-invasive ventilation could be given in the form of CPAP or pressure support, which improves oxygenation and improves ventilation. And it has a lot of beneficial effects on the heart. It reduces the preload, it increases the RV afterload, and then it reduces the LV afterload. And all these have a favorable effect on lessening the burden on the heart with relation to oxygen consumption and reducing the oxygen demand as well. And by effective usage of NIV, it is shown that heart failure could be effectively reversed. And these are the two studies which are shown by effective usage of NIV, intubation could be avoided in 15% of the patients. And it has become a quality indicator that any patients with pulmonary edema, it is mandatory that they do get a trial of NIV, and that has shown to improve the outcomes and reduce the mortality also. So there is this Cochrane study from Canadian group which has shown good use of NIV in patients with pulmonary edema is shown to reduce the mortality. So it is very important that we use CPAP or pressure support, sort of a NIV ventilation for any patient who comes with pulmonary edema, for reducing the risk of them getting intubated and reducing the mortality. So what is the seventh step is to reduce extracellular fluid. How do we do extracellular fluid? NIV helps in some way. Effective usage of diuretics. So there are two types of diuretics we tend to use. One is the loop diuretic. As the name sounds, the loop diuretic acts on the distal part of the loop of Henle. And by effective usage of loop diuretics, there is sort of a diuresis, and there is some amount of venodilation that happens. And it would improve dyspnea, and it helps in diuresis and eliminating excess fluid from the body. So it enhances the fluid loss and helps in reduction of the weight of the patient also. So the effective usage of diuretics helps in alleviating the symptoms largely. And most important is, it is sort of emphasized that diuretics has to be cascaded to higher sort of a doses by monitoring the response, whether there is adequate response to the diuretic that is being given. If the response to diuretics is insufficient, so the dosage has to be increased to a level at which you get a response, and another additional diuretic like thiazide diuretic could be added. And as you see, thiazide diuretic tends to act on a different site. It acts on the DCT level, distal convoluted tubule, and that could be complemented when there is insufficient response to the loop diuretics. And if there is impaired response to the diuretic, it is shown there is an increased risk of readmissions in someone who does not respond to effective diuresis. And these are the patients who have a higher risk of mortality. So that is in brief about the effective use of diuretics. And the eighth component is to effective usage of vasodilators. So the type of vasodilator we use, venodilators like nitroglycerin or sodium nitroprusside. The common ones used is LTG, nitroglycerin. So the way it acts is it reduces the venous return and it causes venodilation. And by doing this, it reduces the preload and then it reduces the LV afterload. So the vasodilators also could help in reducing the coronary spasm, and use of vasodilators reduces the systemic blood pressure and reduces the burden on the heart, and it can reduce the peripheral resistance. So this is in sort of a essence as to how these vasodilators, they basically offload the heart. They reduce the left ventricular afterload and they reduce the preload. They cause venodilation, reduces the venous return, and it can reduce the vasospasm and reduces the blood pressure and reduces the peripheral resistance to the peripheral resistance, which will offload the heart as well. So this is in essence as to how vasodilators act. And there are two randomized controlled trials recently which has been looked at comparing IV vasodilators versus high dose of diuretics. And these randomized controlled trials basically did not show a huge benefit with the use of IV vasodilators, but nevertheless, this remains a part of armamentarium of treating pulmonary edema. And when vasodilators are used, they have to be used with caution in normotensive patients, because any hypotension in patients with pulmonary edema is shown to lead to worse outcomes, and hypotension can increase the morbidity and mortality. So the key essence, which we mentioned previously also, is to avoid hypotension and maintain adequate blood pressure. So that is also quintessence in managing pulmonary edema and heart failure. So that's the 8th point. So the 9th aspect that we would look at is how to avoid readmission. So the readmission, the whole focus of avoiding readmission is to prevent venous congestion. It has been increasingly recognized that in heart failure, the one aspect which increases the risk of readmission and morbidity and mortality is the venous congestion that tends to happen in multiple organs, and that is the cause for readmission. So effective diuresis with good vasodilator therapy is what could possibly mitigate and circumvent this venous congestion. And venous congestion is shown to increase readmission, increase in the mortality. And the treatment goals should be targeted to relieve this venous congestion and treat the underlying comorbidities effectively, and change to oral therapy. And early initiation of AC inhibitors or ARBs is shown to be effective in reducing the afterload and reducing this venous congestion. And use of beta blockers. In acute phase, one could be little slow in starting. Once patient is stabilized, beta blockers could be initiated to improve the outcome. So these are some of the broad concepts of what needs to be kept in mind to prevent readmission. So relieving venous congestion is given a lot of emphasis, and effective treatment of underlying condition. If there is a coronary problem, then obviously percutaneous intervention of some sort has to be done in treating it effectively, and effective usage of early usage of AC inhibitors and beta blockers have to be put on a priority, and effective diuresis, so on and so forth. So the last one that is emphasized is, do we need multidisciplinary teams to improve the outcomes? So the answer is yes. So multidisciplinary team approach in heart failure has shown to improve outcome. I'm sure every listener would know when the heart failure first comes, it is not the cardiologist who sees, it is always the emergency physician. So multidisciplinary sort of a communication and coordination that happens from the ER physician. After ER physician, patient comes to ICU in the middle of the night, you wouldn't expect a cardiologist to be present. So there would be an intensivist who would be managing this pulmonary edema. And obviously cardiologist role is very important in treating the underlying cause. If there is a coronary syndrome, he needs to do an intervention, he or she needs to do an intervention and treat it effectively. If patient is in shock, they may need balloon pumps. So cardiologists also. Effective coordination and communication between these teams has shown to immensely be helpful. And as I said, the pulmonary edema carries increased morbidity and mortality, more so in patients more than 65 years. So there is a reference to involving geriatricians also in a comprehensive management of these patients, because they could be on follow-up with geriatrician later on in the course of the disease. And it is emphasized that the multidisciplinary approach helps in trying to address this organ crosstalk, because there are other organ dysfunction that would have set in, and the cardiologist may have addressed the heart function. It may be the geriatrician or a comprehensive physician or an intensivist who would look at the kidney function, who would look at the liver dysfunction and the GI dysfunctions. All this you need a sort of an overview from a physician who would be looking into it, even in the follow-up period. And so there is obviously no robust evidence in many of the sort of a basic therapies that we have said. So this multidisciplinary team approach would really help in improving the outcomes, preventing or reducing the readmissions, and reducing the mortality, because the mortality and readmission rates in pulmonary edema, as mentioned already, is found to be much higher. So because deaths can happen within 1 year, and as you saw, readmission within 6 months go up to 40%. So the multidisciplinary approach would definitely help in sort of improving these outcomes. So that's in brief about these 10 aspects which intensivists should know. So these are the good sort of a series of articles that are coming in. So I think then in the next video, I would talk about the 10 myths about albumin. So it's good for intensivists to have a good overview of major conditions which we commonly deal with. So thank you one and all. So I would end with this beautiful quote: one doesn't become enlightened by imagining figures of light, but by making the darkness conscious, by Carl Jung. Thank you one and all.